So Carme is an associate professor of public health at her new position at the University of Girona, which is an amazing town, north of Barcelona. Yeah. North of Barcelona. She's the PI of the eHealth Lab research group, and which run and manage various international projects evaluating digital health implementations, but specifically they focus on implementation of digital health interventions in lower and middle income countries. She's directed the Open University of Catalonia's master's degree in digital health, where she held a previous academic position, and she's a member of the World Health Organization's Collaborating Centre in Digital Health. So Carme, thank you so much for coming here, and we're really excited to hear your talk and what you're going to say. Okay. Thank you so much.
Thank you. So thank you so much, Emily, for such a brilliant introduction. I'm very, very happy to be here today. So before starting, Emily gave like a scientific presentation of myself, but I'm going to do a different presentation. So I want to share with you who am I? In fact, I have a bachelor degree in chemistry, nothing to do with digital health, but that was a long, long time ago in the last century. And then I have 3 master's degrees, and I have my PhD was in 2002. So this current century in biochemistry and molecular biology. But maybe the things that identify me the most are the ones you have here. And this means that I love traveling. You know which mountain is that? No.
Everest.
Yes, thank you. I traveled to Tibet this year through Nepal, and we were traveling around the Everest mountain. But I choose that photo because I really love traveling. I love urban sketching, and I've been traveling, drawing in several countries in the world. I'm a big fan of Bruce Springsteen. I've attended more than 30 concerts in my life. And last but not least, I need to have the sea next to me or very close to me because it gives me life. So that's who I am. And from a more professional point of view, Emily told that now I have a recent position at the University of Girona. Before I was here at the Open University of Catalonia, but our research group, the eHealth Lab, is a group between the 2 universities, so that's why I put it here. And last but not least, if I had to identify myself with an app, my app would be Apple Music. Okay, so maybe you ask, what is somebody like me talking about digital health and assessment, somebody who studied chemistry and was in a lab, in a wet lab doing things. And it was a great chemist PhD, what I did. It was about lipids and it was about synthesizing molecules and so on. So what did it happen? By the way, this is Scotland, several years ago. Everything started in 2014, more or less. At that time, I was working for the Catalan Agency for Health Quality Assessment, similar to NICE here in the UK. And I was attending a conference by chance in Girona. I'm not living there, but by chance it was in the same city where I'm working now. And somebody was presenting a tool, so an app, that was for people fighting against the fear to fly. And then somebody in the audience raised a hand and said, okay, how do you know that this works? What is the indicator that you are using for that? Remember, I was working in the Health Technology Assessment Agency, and that person presenting that intervention said, oh, it has got a specific number of downloads. Then my brain exploded. If the indicator we have to say that something is working is the number of downloads, let's stop. So we started at that moment. For me, it was a game changer. So it's say, oh, we have to do things about it. We were busy doing assessment of health technology assessment, but technology means whatever. It does not mean specifically digital technology. So a vaccine, a drug, whatever can be considered technology. So that's what we were doing at that time. So we decided to organize an international group to start moving towards the assessment, health technology assessment of, at that time, mobile health interventions or digital health interventions. So that was in 2017. And I've been working in my scientific career First of all, focus on the evaluation, health technology evaluation, but I'm sorry. From the evaluation, I moved towards the impact. Okay, we can evaluate things, but what is the real added value? What is the impact, the social impact that this intervention is giving? Then I realized how important it was co-creation, so co-design, co-creation, using different strategies like design thinking strategies to work together with all the stakeholders around the specific intervention. And last but not least, so that was my order, starting here, going here, here, and here, I realized the importance of the needs analysis. If you don't do a good needs analysis, you are doing things for nothing. If this is not a real need, nobody will use it. So, I do something, I think, that I shouldn't do. Okay, yeah, sorry. So I'm not going to go in detail with that, but since 2014 till now, I've been active in different areas around digital health. So why so diverse or so different things? Because in our research group, and in my case, our expertise is a methodological one. So no matter if you're talking about mental health, or about telemedicine, or about aging, or about infectious diseases, or about what you are talking about, methodologies are going to be more or less the same. So the thing is that we always work, we never work alone, we always work together with healthcare settings, with other research groups, whoever. And I want just to mention that I'm going to talk about it at the end, is number 9 and number 10. It's about digital determinants of health. I don't know if you've heard about them, and the environmental impact of digital health interventions. So this is the new topics in which we are working also now. But yeah, we have developed several tools. Just for you to know, this is clinical decision support system to choose the best intervention for people suffering from dementia. This is something similar with autism. These two tools, I'm going to talk about it later. These are tools that are apps to assess apps. In this case, whose main goal is to manage overweight and obesity, and in this case, to manage depression. And last but not least, I've been collaborating with a colleague of mine, who is working in an spin-off currently about a tool to recommend evidence-based interventions for people suffering from ADHD. I know somebody of you was working on that. Okay, now about our research group. Our motto is that we co-create in digital health to improve people's health. And this is the group. Why I want to share with you this is because it is a multidisciplinary team with very different backgrounds. So up to now, the group, the PIs, we are the two PIs. That's very funny, because he has a bachelor in physics and I have a bachelor in chemics. You know, physics and chemistry, at least in my context, we are sharing building, and there were some issues there. Then we have two medical doctors, a pharmacist. They are already having a PhD. Emily knows her very well. And then we have master students in digital health. He is also a PhD student. He's a psychologist. Emma is a biotechnologist. She's a nutritionist, physiotherapist, nurse, and physiotherapist. So you see, we are much more into the health area than in the technological area, except for Tony. And he always says, I want more data scientists and people joining my group. Some of the examples in which we have been working about, this one you know it, and I will tell you later. This also I will tell later. This one I mentioned just before is autism. It was the development of an app to support decision-making and psychological intervention for autism spectrum disorder. And what we learned here is that what people need is nothing to do with what scientists say that maybe people need. So that started a lot of years ago. So we were not doing cooperation before the project. So we applied for funds and we succeeded. And we were given some funds to do something that when we did our co-creation sessions, it was worthless for the people. So finally, what we did is to do what we were supposed to do according to the funding. And with those funds, we also decided to do what people wanted. So that was a lesson learned for us. So we've been also in several European projects, and this one specifically is about digital competencies of healthcare professionals applied to the cancer care healthcare professionals. This is really, it seems that it's already done and everybody knows and everybody has the digital skills, but I can tell you this is not the case. So yeah, we've been working on that for 4 years. It's finished. It finished last February. So we have, improved that. Then we have a PhD running about digital determinants of health. I will tell you later. We did this is the PhD of Aina, and it was a proposal for digitalizing the care for mild and moderate depression in primary care in Catalonia. With this project, we learned a lot of things, but one of the things is, okay, if we want to really cause an impact, it's not enough having a PhD, having a thesis, having some papers. We need to do some policy brief, we need to do some lobby to make things move. So we started also following this line, which is not easy because it's very much context dependent. It's very much dependent on the people that you contact in if you really touch something relevant or not for that person or for that group. So that's something. And then we have Sonia that I contact her with Sarah, thank you, because he's doing he's co-creating a digital intervention to manage menopause to improve the quality of life of people in this period of life. And just to finish this introduction, this is who we are, what we do. This is our group. It's not me who designed that. It's somebody who professionally do these kind of things. And we try to put here all the things we are doing in a graphic way. I can share the presentation with you. So if you are interested, you can check this. Okay, so let's go now to the seminar. So the title of this seminar is Why Assessment is the Cornerstone of Digital Health Success. You've seen that I've highlighted 3 different colors, 3 different concepts. So my seminar is going to be around digital health first, second about assessment, and third about success. So what do we talk when we talk about digital health? We probably say, well, that's over. We all know that. You probably know that before beginning of the century, this term was already used, and the definition given at JMIR is the one you have here. It's not only a technical development, but a change of paradigm, a change of state of mind. So at that moment, what was included inside the e-health, we were talking about e-health more than digital health at that moment, were these 10 E's, which I think are completely valid for today. So we are talking, of course, about efficiency and about enhancing quality of care, but we are talking about evidence-based, empowerment, encouragement, the relationship between patients and healthcare professionals, education, information exchange, extending the scope of healthcare out of the healthcare facilities, ethics and equity. So these 10 E's probably are currently very, very important also today. If we move towards close to our reality now, that's 2020, if I'm not wrong, yes. There's a scoping review and a kind of analysis, review of definition that I found that I really like, because it moves farther. So digital health is about the proper use of technology for improving health and well-being of people at individual and population level, as well as enhancing the care of patients through data, clinical and genetic. That was the definition they reached, and I think I like it, in fact. So digital health is an opportunity to address all the health challenges and ensure that health is really a universal right. But as I told you, what are the skills of the people that have to use these digital health interventions? Mainly healthcare professionals, but also citizens and patients. Where are we in that? So is really digital health this key driver for the transformation of the systems worldwide? This is a question. It's not something that we say it is. If we go to the Millennium Development Goals, with 2000. Most of you were not born, probably. So, yeah, I was born. For the first time at the global level, we could see the potential of technology to improve healthcare delivery is mentioned here. But if we go to the Sustainable Development Goals, probably you know much more about them, digital health is recognized as an accelerator to achieve the goals. So, but that was 11 years ago. I stopped because I see somebody taking pictures. If you go to different health systems in Europe or outside Europe, there are a lot of documents, a lot of strategic planning about how to implement, how to improve, how to scale up digital health interventions. But this is not always happening. So the paper stands for everything, but then reality is another thing. So what is mentioned in all these strategic planning papers is that digital health can help in all these things, or there is like the hope that it will help in all these things. So the personalized treatment, personalized medicine, tracking the health issue, the health status of a person, having efficient health data management, reduction of time, again, efficiency somehow, accelerating research and innovation, supporting clinical decision support system, improve adherence to treatments, improve access to healthcare, reduce mistakes, and improve accuracy in diagnosis. So that's what I wanted to share with you about digital health. I know you are in the topic, so maybe you didn't learn nothing new. What about assessment? So I don't know if you are familiar with the idea of health technology assessment. Health technology assessments defined by WHO is the systematic evaluation of properties, effects, and impacts of health technology. What is a health technology? It's the application of organized knowledge and skills in the form of medicines, medical devices, vaccines, procedures, systems, programs. Whatever you do in health is considered technology. So sometimes this is like a false premise because we think we are only talking about digital technologies. No, we are talking about whatever you do, it's considered by WHO and by the bodies of health technology assessment and technology. So INADA, which is the International Agency for Health Technology Assessment, so the gathering of the HTA agencies worldwide, they define the dimensions of HTA. Of course, clinical effectiveness and safety, that was like the basis. But year after year, the number of dimensions that are considered that are relevant and have to be assessed are much more than just clinical effectiveness and safety. So there are costs, economic implications, ethical, social, cultural issues, organizational and environmental aspects, as well as wider implications for patients, for everybody, not for the healthcare system, not for the healthcare professionals, but for the society. So let's move to digital health. We all say, okay, all these digital health interventions have to be the solution for everything in the health system. But does digital health also have a dark side, the same as the moon, or not? So I mentioned you about this idea of number of downloads. And for me, okay, this was an indicator. I don't know if digital health is a solution or is a problem with this indicator. So in 2017, we started with this framework that maybe you have already seen it. And yeah, it was clear for us that we cannot measure all digital health interventions the same. It's not the same if you are giving information or you are doing a diagnosis or you are doing. Now it seems quite obvious because, for instance, the regulation for medical devices is divided into different kinds of devices. I think in UK is quite similar to what happens in Europe. So depending on the final aim and the risk associated to it, the conditions the regulation is different. But at that moment, everything was something gray. It was not clear what to do. So we gave some knowledge to the scientific community with this framework. And for us, it was clear that we had to consider not only the user perspective, being the user, the healthcare professional, but also could be the patient. But as I mentioned before, the impact of the organization, the healthcare system, and the society. So all the things that should be assessed are much more than the effectiveness and safety. Here you have a list of what we decided at that moment. But that was 2017. 2024, I was participating in this working group that was led by the Catalan Agency of Health Quality Assessment, and they were doing a methodological framework based on the scoping review that they had done before and thematic analysis of all the different dimensions and domains that should be considered when analyzing digital health interventions. So you see, I'm not going to read all of them, of course, but you can see that the number of things to be considered when doing health technology assessment is growing and growing and growing. So to make it easy, the 4 domains were 10 years ago, the health problem, the description of the technology, effectiveness and efficacy, and safety. But then, when we talk about implementation, aspects that should be considered are the organizational aspects, human interaction and sociocultural interaction, legal and ethics, and economic aspects. And the last scoping review, the new domains that have been incorporated into all these HTA procedures, as what happens specifically with the technical aspects, so talking about digital in the sense that we know, the environmental footprint, the content, so what's inside these technologies, really, and what happens once it's launched to the market, because it seems it's finished. No, we all know with drugs that you have to continue monitoring their impact. It's the same for digital health interventions. So let's move now to success. What can bring us success? I have divided this into 4 different stories that are different projects in which we have been working on. First thing, the success is linked to the capacity to see, okay, this is good or this is bad. 0 and 1s for computer scientists, which is not my case, as you know. So are we able to separate the grain from the chaff? Are we able to identify those tools that are really giving added value from those tools that are not? So that's why we started one project before that, and this project specifically in 2022, and it was the development of an app to assess apps, as I mentioned before. So we want to assess the existing apps that already exist in Google and Apple to manage depression. Okay, so what can we do to assess these apps? So we started this project that ended last February also, everything ended last February. Yeah, it's true. Why do we focus on depression? Because we are not specialists in depression. We focus there because if we went to at that moment, 2022, to at least from our context, in our repository in Google and Apple, that you know that this changes depending on your access, where are you, we could see that the well-being app and the stress and relaxation apps were a little bit less than 1/3, and the weight loss and diet and nutrition were a lot. And this was our first project, but as it's too old currently, I'm going to talk about the other one. So why did we choose that? Because we thought it was a need. So there's a lot of different apps that you can choose, but are they really bringing added value? Are they good for you if you are a person suffering from depression or not? And before it was the same with overweight and obesity. And not only that, because depression in the 2020s, at least in our context, is one of the most frequent mental disorders. The number of people affected is very high. And we did a data analysis in our context in Catalonia, and we could see that from 2017 to 2022, of course, there's COVID in the middle, the number of diagnoses identified in the primary healthcare public centers increased a lot. I'm just emphasizing public centers because probably before the resources in the primary healthcare public settings to treat depression were not existing. So people, if they could pay, they went to the private doctor or private psychologist. But currently this is changing. So there are a lot of aspects that can really explain or why this increase is so high. But it's clear that the number of people diagnosed is much higher, and the number of drugs taken by people, which indirectly it is together public and private people, we can know that, it's increasing a lot also. So because of all this, we defined in this project that started in 2022, as I mentioned. What was the project about? Very briefly. Sorry, it's in Spanish. First thing we did was a mapping of the existing apps. Then we did a systematic review and meta-analysis of the existing evidence of using digital tools to manage depression. And then based on all these things and our previous project, we had a long list of possible indicators to be considered when assessing health apps to manage depression. So we had to prioritize them. And then we did the Delphi study to reach consensus about which were the most important one that yes or yes should be included in the assessment tool. Then we did some co-creation studies to define how was going to be the interface of this tool, of the EvalDepApps tool. And then we did the prototype, and then we did the pilot test, and finally we validated it. Very shortly, the mapping. We could see that based on our inclusion and exclusion criteria, we identified only 30 apps. That was 2022. Probably this has changed completely. It can be higher or lower because this changes every day. But the important thing was that when we're looking for evidence about these apps, so whatever paper, no matter if it's an observational trial or it's a clinical randomized control trial, we could see that out of these 30 apps, only 8 had something published. And really, evidence supporting them, there was only 2. That was the reality 2022. Then we published this meta-analysis that was 2024, and we were not focusing on these apps. We were focusing on whatever intervention about digital health to manage depression. And we came with 29 randomized control trials. And this is where it's published. 2023, sorry, I thought it was 2024. Anyway, for me, the important thing are 2 things. The first thing is that if you do cluster analysis, you see that the app alone is not really doing what you want it to do. The best intervention is a hybrid intervention between the healthcare professional and the app. The app is giving added value to the healthcare professional. So yes, let's use digital tools, but not as standalone tools, together with healthcare professionals. And the other thing that maybe it's not clear here, and maybe those who are very proud of technology don't like, but the results showed that the most effective interventions were the most simple one. I mean, including gamification, including very complicated things, what made, in general, was to lose adherence and to lose followers and to lose people following the intervention. So when you do all the aggregate analysis, the results are not good. Maybe the interpretation is that not everything is for everybody. So I'm not saying that we don't have to invest time and energy in this kind of interventions, but if we analyze everybody together at a population level, it's not that worthy. That's what the meta-analysis showed at that moment. About the Delphi, it was a 2-round Delphi. I'm not going to go one by one. We invited several healthcare professionals, multidisciplinary completely, so social workers, nurses, physicians, psychologists, psychiatrists, etc., and people suffering from depression, of course. And after the 2 rounds of the Delphi, we ended with 28 criteria. What does it mean? 28 criteria, so the criteria that are included in the tool to assess apps. So yeah, more details here. And this is the content. So the 28 criteria are around these 7 dimensions. So about safety and privacy, you have all these topics, clinical effectiveness, and then purpose of the app development, usability and functionality, health indicators, and reliability. So that was the result after the Delphi. We say, okay, these 28 indicators are the ones that have to be measured to give a score to a specific app for depression. And then we did the co-creation workshops. following design thinking methodology. I know you are familiar with that. And at the end, we have this app, which is available, and you can use it, but you need a code to download it. If any of you is interested, I can give it with no problem. It's in English also. It's in Catalan, Spanish, and English, so you can use it, Miquel. You can use it in the language you want. And how it looks like? It looks like that. That here are the apps that we were asking the people to assess. And then after the assessment, you rate the app, and then you have here the score that you have given to the app based on all these questions. So it works like that. At the end of your assessment, you can be the ranking, or you can see the ranking once you are registered. And so we did the pilot test, and what we did, so 8 healthcare professionals and 6 people with depression. We gave them a specific app. Which apps? The ones of the mapping exercise? No, they no longer existed in the Google and Apple. So we had to do it again. And we were asking all the time the healthcare professionals, it looks like good to you according to our criteria, because we don't want to do more harm than good to the people participating in the study. So they were using the app for 15 days, 2 weeks, and then we asked them to score the app. And that was the result at that moment. It was interesting. So the pilot test helped us to identify things that we could improve in how the questions were made and this kind of thing, and some technical issues, but not that many. And yeah, it was interesting to see that thanks to the tool, we could discriminate. So the score was not the same for all the apps. And even if we're similar, the dimensions in which it's scored different, it's clearly identified. It's easy to be identified. So depending on your preferences as a healthcare professional to your patient, you can prescribe one or the other, knowing which is the score. But these were a small sample, of course. So we did the validation, and that's the number we finally gathered. 71 healthcare professionals and 59 people with depression is not easy, I can tell you. For the healthcare professionals, it's easier, but they have a very high level of burnout currently, and it's difficult to recruit them. I see you doing like that, so you understand me. You understand me. But imagine people suffering from depression. So if you are asking people suffering from cancer or from rehabilitation from a stroke, it's different. But depression itself makes people say, yes, I'm going to participate, but at the end that doesn't happen. So we're very happy about the results. And so we added a new app here. We had identified 3, but it was 1 year later, and we identified another one, which was the one, that's funny, the one recommended by the Catalan government. And then 2 weeks, again, the same procedure. And the results, I really don't have the final results, but so we also took the opportunity to ask the people about their social demographic data. Most of them were women. Most of them were middle-aged. Most of them were living in Catalonia. This project, by the way, was done in Catalonia and the Canarias, in the Andalusia region. It was not only in Catalonia. And this question was, would you use these apps in the future? And people, 43% said never. In a regular way, only 13%, and in a sporadic way, 44%. So, okay, that's not the best results. And then if we gather all the results together of all the different apps, we could see that in general, usability and functionality were quite well scored, while, for instance, reliability and security and privacy were not, of these 4 apps that we were analyzing. Results of the apps, I don't know if I have the final results, I don't think so, no. But just for you to see that WISA, for instance, was 80% well scored. This one was 81%, not far away from the results of the test, although the sample size was much higher. But the one recommended by the Catalan government was around 50-something%. So I don't know why they are recommending this tool. It's not the final results. So we are analyzing them and we hope to publish them during this 2026. But we are just analyzing them. And based on a conversation that we had with Amberly, a lot of people ask us, but did the analysis separately, healthcare professionals and patients? We have done the cluster analysis and we have done the aggregate analysis, and there are no differences. That's something that we were not expecting. So we were expecting to see big differences, and there weren't. So not bad. So what's the lesson learned from this first success story? It's very important to do this needs analysis in a specific context. You have to consider which tools you have already available, not to reinvent the wheel. You have to look at the existing evidence, definitely. Very important teamwork between healthcare professionals and citizens. Do pilot tests in real settings, not in lab conditions, because reality can be very different. And use big sample size if you can. We consider 130 big sample size, which I know it's not a big sample size, but considering how difficult is the recruitment, we're happy with that. Okay, let's move to the second story that I see Emily's face, and it's based on this app. Do you all know the story of the app? Because I can skip this part if you know the story. Where did everything started?
You might be able to maybe give a small recap.
Yes, more recap. Yeah. Everything started in 2018 when this guideline, Clinical Management of Neglected Tropical Diseases, Skin-Related Tropical Diseases, was published. Very soon after that, it was clear that this book was not used and nobody was even having it. It was a physical book or a PDF, no matter what it is. So they just digitalized. Whoever WHO gave this task to be done. So they had this app digitalized, these guidelines digitalized. And then it was merged with another existing app that was developed by leprosy helmet. Thank you. National Leprosy Research, whatever. Anyway, they had another app which was for common skin diseases. So they merged two apps, and we had the second version of the app. And there were some changes, and there was an app which is now available at Google and Apple, and you can download it and use it, but it's not a responsive app, okay? And it has no AI embedded on it. So this is like the evolution of these clinical guidelines, including common skin disease. This is a capacity building tool. And then in 2024, AI was yes included here, and that's the PhD of Emily is about that. This is the version 3, the one without AI, how it looks like. It's just to learn how to identify, how to treat, how to manage these skin conditions. And we did the first study that was we were asked to do this study before COVID, but then because of COVID, we did everything online. And it was analysis of usability and user experience from healthcare professionals in Kenya and Ghana. So very interesting. We use the UMARS tool that probably you are familiar with. And we did it this is Cameroon and this is Kenya and Ghana. So if we compare the three settings, results are very much similar. Specifically, this was done in the same moment in Kenya and Ghana, and they are almost overlap one with the other. So that's good for the app. That means that it's the same good or the same bad, no matter the context. So that's cool. And that was done by a PhD student who's going to present his PhD soon, Henry Mungmi, in a different setting, which was Cameroon. So then, as I mentioned, AI started, and then this is how it looks like, the app currently. Probably you know a little bit. There are two different algorithms embedded on it. One is specifically for skin neglected tropical diseases. The other one is for skin common conditions. Why? Because different developer has developed these two algorithms, so they are completely separated. This is how it looks like, the one of the skin entities. So that's, you take a photo and you upload it to the app, and the app gives you these potential results. So the objective of the project was, at that moment, was when we did it, we started in 2024, 2 years ago, to assess the usability of the NTD app in the real world in Kenya, and to assess the accuracy of the AI algorithms. So these are some photos of the first workshop. We went to Kenya in April 2024. It was San Jordi Day, Mikel, for your knowledge. So we just gave some roses to the people. It was some sweet roses, but then bees arrived. So it was not the best option with it. Anyway, that's something cultural.
No books.
No books. Books. There were 50 people participating. 50 books could have been overweight for the play. So we were there just training the people about the features of the app and learning them how they had to use it and take the photos and upload the photos so that we can analyze them later. So what happened at the end is that we collected 605 patients, photos from these 605 patients from different counties. And what we tried to do is to analyze the accuracy of the AI algorithms, the one for skin and disease and the one for common skin conditions and the global. What was the big problem, the gold standard? When you ask the AI, which is the potential result of this skin lesion, the AI tool tells you maybe is this is number 1, this is number 2, 3, and 4. Then what we did is to look for 2 dermatologists, one who is the ones who developed the guidelines in 2018, so he's quite well skilled and he knows a lot about all this, and another one from Kenya, specialized in the endemic problems in the region. So, and we were sending them the photos with no other information and no the result of AI, of course, and saying, based on this list of diseases, do you think that person is suffering from disease 1, yes or not? Disease 2, yes or not? It was like that. And we expected some correlation between the 2 dermatologists. Welcome to the real world. No, there was very, very small correlation. So we invited the 3rd one, thinking that this was going to be easier. We are really suffering about how to analyze data because it's not clear that 2 of the dermatologists are correlating and one is just an outlier. This is not like that, depending on the photo, depending on the disease. So we think we always are validating AI towards clinical opinion, that maybe clinical opinion is wrong, because if you have 3 different results for the same photo, what's the truth? The truth would be if we were able to have like a molecular biology test, a PCR or similar, but you are working on the field in rural areas in Kenya, that doesn't exist. So there we are. That's from the second workshop. Emily was there and she is working hard in publishing the paper based on the results of this qualitative study. We also asked the people to analyze the usability, and that were the results, not bad. Of course, engagement was the less well considered. It's obvious, I think. And I think Emily knows a lot about that. Just very briefly, out of the qualitative study, what can we conclude is that before the app integration, that were like the workflow, more or less, and you see how it changes after the app use, according to the healthcare professional's opinion. So it can be a game changer, in fact. So some lessons learned from this real world validation. Again, a needs analysis was not done here. That was the idea, WHO. Let's do that, and sometimes this happens. Scientists and developers, I know how to solve this. But this was not done with the people on the field. It should have been done. It's very important to do this capacity building of the final users. Again, the validation in real setting with big sample size. Analysis, one thing is the analysis of the standalone product, usability, accuracy, but what about the analysis of the implementation in real settings and the patient perspectives? So that's something that we saw that it was missing here, and that's Emily's tasks that she's working very hard on that. Let's move now to the 3rd success experience. And if you remember, I shared with you this screen in the beginning. Is digital health really the key driver for the transformation of the healthcare system worldwide? I don't know if you are familiarized with the social determinants of health. but this, yes, I see your faces, most of you. So you all know about the thing that we are not only biology. So there are a lot of conditions that can determine our health. But what about technology? Is technology a new social determinant of health? So the use of technology, what is the impact that can have I'm talking now about our health systems. So maybe is increasing health inequities. They exist, digital barriers and exclude population. What about privacy and data risks? Over reliance on technology, techno-optimism, algorithms bias, we know about that, fragmentation of care. So there are things that at least we should consider when talking about digital health interventions. So what are the determinants, digital determinants of health? They refer to condition factors linked to or dependent on digital technologies that in a direct or indirect way, they influence health and well-being. So they can operate at different level and they can determine the health of the population. So there are a lot of different frameworks that talk about digital determinants of health, but this is very new. So currently, one of our PhD students, Mireia, she's doing first a scoping review of the existing frameworks. She hates scoping reviews, so it's not yet finished because she's taking longer than expected. I can tell you that because we have laughed a lot about that. But it's clear, I think that that's one of the ones that we have identified that I like the most. And is this one here? What happens when we consider technology in all these different aspects? So a lot of things could be modified. And which are these things that could be modified? So for instance, the bias, as we mentioned, of healthcare professionals, the digital literacy, the misinformation in the social media, this is causing also something. Digital marginalization. This, I don't know about the UK, but in Barcelona, it was very clear during COVID time, the vaccine strategy was completely through digital tools to ask to go to the healthcare setting to receive the vaccination. And then it seemed that in specific areas in Barcelona, the number of anti-vaccines were very high because the number of people getting the vaccine was around 50-60%, while in other areas was 90%. And it was not like that. It was that this information was not reaching the target audience. So what the municipality decided to do, it was to do a hybrid strategy. So through the digital means, but also being there physically and asking the people on the street, and they were, I didn't know about that. What I have to do. So they helped them to apply for a specific hour to take the vaccine. So the results were the same no matter where you were living in the city. The number of anti-vaccines was very, very small. And that was creating a marginalization. And so that's something to consider when you decide at the system level to implement a strategy. Yeah? Also the access, internet connection, of course, infrastructure, data protection, acceptance, depending on your context, depending on your target users, that's going to be different. So we are not very far away in this PhD. The next thing we are going to do is to analyze the bias of healthcare professionals when prescribing digital health intervention. So that's going to be in a big hospital in next to Barcelona, in Badalona. And we are now asking for the ethical allowance there. And the thing is that they have like a kind of digital portal, but it's not prescribed to everybody. So the professional decides to whom to prescribe and to whom not to prescribe. So we are doing a project now to identify if certain preconcepts are guiding and are biasing the healthcare professionals towards to whom to prescribe what. Okay, so there we are. Lessons learned. So be aware when you talk about digital health intervention about vulnerable communities. It's digital for all or with all. So bias, infrastructures, accessibility, and what about offline tools that can be useful? Because, I don't know here in the UK, but I know in Catalonia, it seems that everybody's connected. That you go to specific areas where a lot of people, old people live, And the data connection you have there is like, you know, when I was a child, E.T., you know, it seems like that. Eh? So let's move to the fourth story I want to share with you. Yeah, very deeply. I talked about technology. What about environmental impact? I don't know if you know that, but we are getting bad. So that's the final story. So the climate change and a lot of environmental indicators are showing us that we are not doing good for the survival of the planet and society as we know it now. So if we have extreme temperatures, things will be worse. And depending on the country, the consequences are going to be one or another one. So in our country, it happened 2 years ago. You know about that. And these are two photos that I will share with you. That's from the WordPress photo. I don't know if you know it, but it was I took these photos from photos last December. The one it's Brazil. The one in the US, in the left is about the Amazonian region without water. And the one on the right is after flooding in the south of Brazil. So that's the reality in the world we're having now. So going digital is good or bad for the climate? I'm finishing. So digital health is truly healthy, yes or not? But does it compromise the planetary systems? So very deeply, I just want to go here. It is very important to measure the environmental impact of any intervention, including digital health interventions. And that's it.
No worries. We normally have this room booked for another 30 minutes, but I think there's been an error for the room booking, so there's people waiting outside.
Okay.
So if you have any questions online, do feel free to type them in the chat, and we can like ask them after this. But we will end the meeting here. Thank you so much. Amazing talk.